All right, and welcome back to another episode of BackTable OBGYN. This is your host, Mark Hoffman, and we've got two great guests today. We've got Dr. Wendaline VanBuren. She's an associate professor of radiology in the Mayo Clinic Department of Radiology. She's the chair of the GYN imaging section in the Division of Abdominal Radiology and the founder of the International Endometriosis Imaging Congress. And then Dr. VanBuren, we typically use first names on the show. Is that okay with you?
Absolutely. Please call me Wendy.
Wendy, all right.
Yeah.
And an old friend of mine, Dr. Tatnai Burnett, minimally invasive GYN surgeon, also at Mayo. He's an assistant professor and minimally invasive GYN surgeon in the Mayo Clinic departments of OBGYN, surgery, and pediatrics. And they're the co-directors of the Mayo Clinic Center for Complex Endometriosis. Did I get all that right?
Good to go.
Sounds perfect.
Wonderful. Well, welcome to the show, guys. We're glad to have you.
Thank you.
So glad to be here. Thank you for the invite.
Hard to make an asymptomatic patient feel better, right?
Exactly.
I think
exactly.
if they're doing well, and the other piece is if we think there's a medical management component of endometriosis, right? I mean, are you telling patients surgery is a cure? I mean, we do the surgery, we diagnose it, right?
I do not tell them that.
If you're going to recommend hormonal suppression after surgery,
Exactly, which I always do, especially for younger patients.
Or if they have primary dysmenorrhea and there's no endo, you're going to say, well, you ought to think about hormone therapy again. If the treatment's going to be the same either way. That's sort of how I've rationalized or justified. Let's start with that.
The younger patient who's keeping their uterus, you're going to have potentially cramping even after removal of endometriosis with the uterus. What are we going to do about that, right?
Or they have adeno, right? Which is like, that was Keith Isaacson's whole thing. Like, how many patients that have adeno?
Yep. And even if they don't have adeno, sometimes they have dysmenorrhea still. So one of our big struggles is the young patient who you treat with complete excision surgery for endometriosis and they still have dysmenorrhea. That's often a tough one. In any case, so that's the patient with no prior surgery and negative imaging.
A symptomatic patient.
Symptomatic patient, correct. I don't operate on asymptomatic patients except in some very rare cases. In the patient who has bowel symptoms, who has bladder symptoms, published on the higher likelihood of finding deep endometriosis in those patients, we proceed with advanced imaging in those patients. Now, we do have a higher volume of MRI in our practice. That's where we started, and we'll talk a little bit more about that, I'm sure. We also have started developing, I would say we, like it's me, but it's really Dr. VanBuren here who's spearheaded that.
We know.
Advanced ultrasound, which does give us this beautiful view of everything that's close to that posterior fornix. Some modality to evaluate for deep endometriosis prior to surgery for those surgical planning purposes. It's also my belief that patients deserve to have one high quality surgery without the diagnostic lap that we used to do in the old days to say, okay, what's going on? And then I'm going to plan my surgery. No, we have enough tools now to plan our surgery and to do that one surgery right the first time. So imaging allows us to do that. It allows us to plan the surgery. It allows us to counsel the patient. What is the endometriosis involving? Is this a 21-year-old who wants future children and endometriosis is invading 50% of her cervix? And then we have to have a discussion about trachelectomy or, what is needed to really remove all disease if we go down the surgical route. And having that discussion in advance, I'm thinking about a specific patient we had who, was able to meet with maternal fetal medicine ahead of surgery. He was able to meet with gynecologic oncology for assistance with the trachelectomy and figure out all of the different aspects to that care before being in the operating room, instead of just saying, we'll go in there and we'll figure it out. She has a chance to make an informed decision beforehand. So that MRI in that patient allows us to have information ahead of time for the patient's autonomy, for their counseling, for their decision-making, for our planning. So we have everything arranged to do surgery correctly for them. And it just really makes that surgery become more utilitarian and no peaks and shrieks, so to speak.
No, I think that's a really important piece of having this kind of center or partnership between radiology and surgery, in our case, gynecology. So I've got colleagues in radiology I've worked with closely. I've got colorectal colleagues who are interested, specifically interested in endometriosis, because what I don't like is surprises, right? So my pelvic exams are thorough, right? I don't want to miss something. I had one patient who declined an exam. We got in there, she wasn't having bowel symptoms, wasn't having, ultrasound was normal. Got in there and found severe rectovaginal disease, right? Likely needed a discoid, hadn't done a bowel prep, woke her up, told her, listen, we had to bail on this. This is, and she's like, okay, you know what? Let's try birth control pills. and like was glad we didn't, and has been asymptomatic knowing what we got into. But that's the rare case where like she didn't have the things that would get the MRI, declined the exam knowing. I said, listen, there's some things we might miss. She goes, that's fine. And the rare instance. But ultimately, when we get into surgery, the last thing, I think patients understand complications. I think they don't like surprises, right? And so preparing someone, listen, could be an ostomy, could be all these things. Okay, they have time to process. They have time to make that decision. And so, Wendy, that's where you guys come in, is where you can help us out and help us understand what we're getting into as much as we can before we get in there. Talk to me about sort of how you approach endometriosis imaging, what you've learned along the way, what makes working with GYN surgeons allow you to be better at what you do.
So yeah, that's a great point, because I think that, where you start and that process of ongoing refinement of our practice truly is practice, right? So, and we all know that. And so when Tatnai and I started, it was a really casual process. And we just said, why don't we start off imaging your patients before surgery? We'll look at the MRs before, we'll discuss them afterwards. And then it turned into a weekly interdisciplinary conference. And, we started to review those patients with a lot of depth. So I don't know, I think, now we review probably about 7 patients a week in depth like that. We image more than that, but over the last 10 years, that's somewhere in the order of 3,500 patients, probably closer to 10,000 or more that we've imaged. So if you take all of those small learning moments and extrapolate them with layers of learning in each case and understanding each person's whole clinical picture, which I think is a really unique attribute that I've been fortunate to have, is that I get to hear the whole clinical history, the presentation, and what really is driving their clinical outcomes, their desires, the things that they're looking to achieve out of their visit to the clinic, but also to having the opportunity to work with a variety of our specialists. So, between Tatnai and then Zarak and Adela, their patient populations are slightly different. And when they go to see Dr. Khan, they might have more of a fertility-oriented mindset versus Tatnai or Adela. And so, you get to sort of know the patient populations of your surgeons and what the variables might be. Those considerations also, they play a role. So it becomes about not just the operative planning and the intricacies that go along with that and the multidisciplinary care. It's also sometimes the specific questions at hand. And sometimes those are multi-phased, so what is the goal right now? Is it achieving pregnancy? And, what's the time frame look like that for that individual? What are their time or, even financial resources, for example, their availability to achieve things? What are we able to do for them? Sometimes, wanting to trial multiple stages. So we have a lot of patients at very different stages of management. So that's another new aspect, is taking a look at someone who wants to trial medical management, following them for a certain period of time. The difference between surgical management and radiological management is one time point versus many time points. I mean, hopefully, right? So the goal is obviously one surgery, but, we have many patients that are in follow-up.
So tell me, you said your medical management versus imaging management. How did you describe that?
I think what he was saying is surgical versus imaging, which is follow-up management on patients who are either expectant management or on medical management with deep endometriosis.
Are you doing an MRI, trying medication, and then repeating imaging later to compare potential disease progression? Are you looking for disease improvement on MRI? Tell me, in terms of medical management, what you're using imaging for.
Yeah, so we do. We have a variety of aspects that we're looking at. So some of them are monitoring for malignant transformation. So we do have, pretty significant patient population that either show borderline or carcinoma, either presentation or changes. And so we're able to monitor for that within our follow-up practice if they're not undergoing surgery. So for me, that's always, the highest level of concern. I think any radiologist, no matter what you're doing, you're always screening and being mindful of malignancy.
Is this endometriosis patients that look atypical? Is this just like, what percentage are you concerned about that end up turning out to be cancer? Because Tatnai, numbers for...
If you think about what we think about for endometriomas, right? In general, we recommend follow-up for endometriomas indefinitely while they're present, while they're visualized, yearly ultrasound, because we know there's somewhere between a 2 to 3% risk of malignant transformation in endometriomas. So in general, if you read ESHRE guidelines or otherwise, we recommend indefinite follow-up of endometriomas while they remain present, because the longer they're there, the higher the risk of malignancy, higher malignancy risk when women are older.
Are you doing like oophorectomies at menopause then? If they've got one, you just don't leave them there?
That's a conversation with patients. It depends.
Interesting.
But a lot of these patients, of course, are coming pre-menopause. So many of our patients are premenopausal. But Endometriomas you can do with ultrasound. Deep endometriosis, you either have to use advanced ultrasound or MRI. And we do not have anywhere near the level of data with deep endometriosis and malignancy that we do with endometriomas, because, of course, we've seen endometriomas for years. Simple transvaginal ultrasound, we have that data, right? So we've had a long history of following endometriomas and understanding the relationship to malignancy. We don't have that long history with deep endometriosis. I don't know if you recall, there was a recent, I believe it was JAMA article that came out looking at relationship between different forms of endometriosis and malignancy. And it actually found a slightly stronger relationship with deep endometriosis and endometriosis-associated malignancy than it did even with endometriomas. So we've known about the relationship with deep endometriosis, but we haven't well characterized it. So when we started looking at deep endometriosis on MRI imaging, which is how we started, we asked the question, should we be following this like we follow endometriomas? If we think that there's a risk of malignancy when we're following endometriomas, should we be following the deep endometriosis? And the answer is we don't know, right? Because we don't have the prospective data.
I feel like this is an entirely different show. We
Yes.
need to have you guys
Yes.
back and talk about this. I mean, this is not old information. This is not how you train, Tatnai. This is not how I train. This is not how we've been practicing. I mean, it's just, how many years would you say this has been a topic in your mind? Because it's not something that I would say most of us in our MIGS world talk about with much regularity. Are you seeing it differently?
When we started imaging this, the question was, should we be doing something different? And the only way you get prospective data, Mark, is if you get prospective data, right? So until someone decides to image these ladies and follow them and knows what goes on, we're never going to know. And we also have a suspicion that, when you see deep endometriosis of the rectum and it comes back as adenocarcinoma, who sees that first? It's probably Dr. VanBuren or the colorectal surgeon, right? And you get a biopsy and it comes back as adenocarcinoma, and they're like, oh, great, it's coming from outside the bowel. It's already stage whatever, probably not getting operated on. They get chemotherapy. So we've been dying to do this study to look retrospectively at some of these colorectal cancers that have an MRI signature of endometriosis, and do the additional stains on these to see, that's a side topic, but how many of these are we missing in calling carcinoma of the rectum and sigmoid? But I digress. We don't have the prospective data to know. We have enough information to know that there is a risk of malignancy. We think that it's probably about the same level of risk as endometriomas. And so we are going ahead and imaging patients sequentially for that. And there's obviously no protocol written for this. So we start out with a repeat MRI in 6 months in someone who has deep endometriosis found, if they're not going to surgery, whether they're on medications or not, just to look for stability and no changes. I would say, anecdotally, most patients are pretty stable at 6 months, but we have seen a few cases of rapid progression, which also makes you concerned about how you manage these patients. And we occasionally see mild progression, especially in patients on expectant management. And when disease is close to the lateral uterosacral, close to the ureter, should we be concerned about that silent renal death ahead of time, right? When disease is low in the rectum and it's going to change their risk for rectal surgery because it's now a centimeter lower than it was before, does that change how I counsel them on their management, on their prolonged management, right? So it actually does end up being something that affects how we manage patients. And Wendy and I have published on that together as well. But anyways, our protocol right now is we do 6 months if they're stable and we don't see any concerning features. We do 1 year after that. If that's stable, no concerning features. We'll typically do 2 to 3 years after that, stable, maybe 5 years after that, and then expectant management with symptom-only follow-up after that. So that's kind of, we pull that out of thin air just to say, how do we address this? That's
just
not
to
really
set up
being
some
addressed.
protocol, just to do something to go back and measure.
Exactly.
Now, Wendy, do you guys have specific protocols from a radiologic standpoint as you're ordering MRIs? I mean, I know that if I get an MRI from outside my institution, it's going to be different than the MRIs that I get. And I'm guessing you guys are just a little picky in how you perform your MRIs.
Yeah, definitely. So, we do it with a microenema technique to evacuate the bowel gas. We use glucagon to aid with cessation of bowel peristalsis, which creates motion artifact. Then we also give vaginal gel to distend the vagina, so we're able to assess the vaginal fornices and the depth of invasion there. We've published through this Society of Abdominal Radiology consensus agreements on protocols, so that includes small field of view imaging to take a look at the deposits. A lot of times we'll do oblique axial imaging through the uterosacral specifically to take a look at disease there as well. So I think that having the proper protocol is really critical. You can have a pelvic MR that's done large field of view, like an enterography, for example. There's no chance with that resolution that you're going to see the findings that you need to see.
You'll see nothing.
Right.
You'll see nothing.
So it's just generally not useful other than for endometriomas, which could be seen, essentially with any modalities.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Yvonne Orgodzinsky.
Show notes and social media by Emma Landenwich
and Lindsay Beecham.
Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own and do not reflect the views or positions of their employers or any entities they represent.